You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is August 29th, 2025. Our topic today is exercise-induced bronchospasm. This is presented by Dr. Chris Miller, an assistant professor of pediatrics and is the Allergy Immunology Fellowship Program Director at Children's Mercy Hospital in Kansas City.
Conferences online and allergy. This is Chris Miller, the director of COLA. Today is August 29th, and our first talk will be me talking on exercise-induced dyspnea and exercise-induced bronchospasm here. So with that, we'll get moving. Disclosures, I have nothing to disclose today. By the way, this is Hospital Hill. It's a 5-10K and a half marathon that occurs in the 1st of June each year. Terribly hot, extremely hilly, but fun to run. Overview. So we're going to start with some definitions here, and we're going to start with dyspnea, because the complaint you'll hear from most people is they may say I have exercise-induced asthma, or they may say I think I have asthma, I have trouble exercising, and their comments will just, it's difficult to breathe. So I want to define dyspnea because it's not an uncommon initial complaint. So it's common in both athletes and it's non-athletes. They'll say can't catch my breath, difficulty breathing, and then sometimes you hear about can't keep up, like out on the soccer field. The true definition, there's multiple, the sensation of feeling breathless or experiencing air hunger, an uncomfortable sensation of breathing, and then a subjective experience of breathing discomfort that consists of qualitative distinct sensations that vary in intensity. And we're going to move on to the case study. This is an 18-year-old male who's in competitive soccer playing 6 days a week, reports cough and chest tightness in 5 minutes of practice or competition. Symptoms improve with rest but don't fully resolve. Seems to do better as the game continues, and notes a repetitive cough for 2 hours, several hours after the game. And these kind of complaints in the scenario are important. You'll see where this will bear out in some of the data too. No history of asthma or use of asthma medications. Had recurrent bronchitis as a toddler. Reports frustration in not being able to remain in the game. He does not have a history of syncope or palpitations. He does have allergic rhinitis. No family history of heart or lung disease, and then obviously referred to a specialist. Let's first go into differential diagnosis of this young man presenting with dyspnea. So first we'll throw it into lung disease, and you've got two different categories in general. I guess you could have mixed, but we've got obstructive lung disease and restrictive lung disease, and under each column you'll see we've got asthma or EIA or EIB thrown in together. We've got COPD, and we had our talk on overlap syndrome recently. We've got bronchiectasis, CF, we just had a talk last week on that, upper airway disease, and then VCD and other names that resemble the VCD spectrum. And then we've got restrictive lung disease like interstitial, occupational, hypersensitivity, pneumonitis, neuromuscular, obesity, and pectus excavatum. And then there's more. Don't forget about the cardiac things that may present with dyspnea. Hypertrophic cardiomyopathies, dysrhythmias, vascular rings, AV malformations, and CHF. And then other pulmonary, if it's acute, you remember about pulmonary emboli, and then pulmonary hypertension. Other, I throw it in as exercise tolerance, or you could call exercise intolerance, when just physiologic limitation of their airway. I see that frequently. Anxiety, big component, obesity, reflux. There's your exercise-induced food-dependent anaphylaxis, could have a mass, could be idiopathic hyperventilation. And this next slide is on EID, dyspnea, and this looked at people presenting with the symptoms. This is from 2005, and I believe it's more pediatric. And it basically took those individuals and broke them down into categories with final diagnosis. And so some of them were, on a treadmill, and there's with normal condition and then poor conditioning. So, of all these patients, only 8% actually met criteria for EIB. with asthma. Some had restrictive, a good chunk had VCD, laryngomalacia, hyperventilation, SVT. Reflux was a common finding too. So I think my point on this is when somebody presents with dyspnea with exercise here, one, it's not all EIB/asthma. There are many other things that are out there. So today we're really just going to focus on the EIB component, but keep the differential in mind. So initially this was termed exercise-induced asthma, but it's kind of misleading. It may imply that exercise is causing the asthma, kind of not necessarily true. We don't want people not to exercise thinking their asthma will flare. I can't exercise is what you'll hear sometimes on that. And it's almost like an excuse not to, and exercise actually is helpful in people with lung disease. So it's kind of been renamed to exercise-induced bronchospasm. And it can be found in individuals with asthma and without. So it can be its own entity or it can be combined with it here. So more formal definitions: acute bronchoconstriction triggered by exercise, which may occur in the presence of established asthma or in the absence. And it's a transient airway narrowing that occurs most often after exercise in people with or without asthma. The symptoms of EIB resemble what we know about asthma: shortness of breath, cough, wheezing, chest tightness. The more subtle symptoms here: fatigue, I feel like I'm out of shape, performance changes. You'll hear a lot of I can't keep up like I did last year. And then some will have abdominal discomfort. And if you think about it, if you're pushing yourself like in a soccer game and breathing heavily, you use a lot of abdominal muscles to move that air. So here's the pathophysiology. So you've got your strenuous exercise, mostly aerobic. That creates a hyperosmolar environment. So it's the dry air going into the airway with compensatory water loss, leads to transient osmotic change on the airway surface. And that leads to mast cell degranulation with the familiar mediators like leukotrienes, histamine, tryptase, and prostaglandins. Eosinophils are activated. You get more mediators. You get bronchoconstriction and airway inflammation. Sensory nerves will release neurokinin, and then you'll get a release of gel-forming mucin. That's the MUC5AC. Exercise itself is not needed to cause the bronchoconstriction, but it's more the creating the hyperosmolar environment. And we'll talk more about that. And cold air is a perfect ground for that. All right. So this is a graph on the time is on the bottom, and changes in FEV1 from baseline are on the vertical axis here. Going up is a positive change and increase in FEV1, going down is a negative change or loss of FEV1. And then what it shows is that within 5 to 8 minutes of exercise here, you get a little peak increase in FEV1, and then initially with exercise, you get a little peak of FEV1, and then about 5 to 8 minutes into it, you start losing some of that FEV1. In this case, it goes down to about minus 22 or something like that here. Then there's a little bit of a rebound recovery, not quite back to baseline here. And you can also have a late phase reaction where you may dip again several hours later. And this is looking more at the pathophysiology here. On the bottom axis is volume liters per minute, and on the vertical is your change in FEV1. This is looking at the very top is from walking to jogging to running, so that the degree of aerobic exercise is increasing as we move to the right. And then with the different colored lines on this chart, we've got summer, fall, and winter, and I think that's a way to say it's getting colder as we move vertically here. And what you're seeing here is a greater change or drop in FEV1 at the maximum when it's cold air, that'd be the winter time, and you're doing more aerobics such as running compared to, you say, the summertime and running here. So a lot of athletes that have EIB will tell you, I'm okay in the summer, but I cough like crazy in the winter. And it's the cold air leading to the hyperosmotic effect. On this one here, it's the time course of exercise-induced bronchoconstriction in an asthmatic patient, and it's with the FEV1 falling. This is actually on a cycle here. The This is time after exercise on the horizontal and the change in FEV1 on the vertical. Cycling is consistent throughout here, and what you're seeing is with this time is that the FEV1 just keeps dropping, and then you get a slow recovery with time alone, even without medication coming back here. Again, it's still suboptimal from your baseline. And then we do know there's an EIB refractory period with this. It's time on the horizontal and FEV1 on the vertical here. If you do a first challenge, the exercise of the green bar, and you do a challenge, you can see they drop their FEV1. This is measured in liters quite a bit here, and a little bit of a recovery period still while they or after they've stopped exercising in this case. If they did a second challenge on this here, they don't drop quite as much on that. So there's some refractoriness into that here. And that's what's really going to support one of the treatments is warming up before an event if you have that opportunity here. So if you're going to be a miler on the track, it makes sense to go out and get that heart rate up to about 70 to 80% of normal, sustain that. And that kind of builds in a little bit of a refractory period too. The prior information about the cold air, that kind of supports the use of wearing like a mask or muffler or preheating the air if you can. That's not going to be very practical in most sporting events here, but if you're just out training, it might be of help too. And I used to think that was crazy to wear some type of bandana or mask or something when you run long, but COVID proved us wrong and people did it. I just don't think it'll be sustained. Here's EIB by the numbers here. Prevalence is poorly understood because there's really no diagnostic gold standard in it. It occurs in commonly 50% in individuals with asthma have it, so having baseline asthma and EIB. And then 5 to 20% of individuals are without asthma. It's more common in endurance athletes, and I'll show you some data on that. It's more common in the female gender, girls more than boys, and women slightly more than men. And then in some ethnic backgrounds, African Americans have it greater than the white population. Long distance runners, 17% will have that compared to short distance runners, or 8%. I think this is more the aerobic capacity on that. And then runners, 28% have it in the winter, but only 7% have it in the warmer months. Swimmers with, I've got chloramine. I was trying to look up if it was supposed to be chlorine versus chloramine. I have to go find that article, but have a high prevalence of it. And it does decrease when they stop swimming here. You would think with all the moisture around the water, they'd be okay, but there probably is a little drying effect with their intense aerobic exercise. Skaters, they're obviously on cold ice doing this here, so it's a pretty high number in them. And then it's really common in U.S. Athletes here, Olympic athletes here. A large portion of them have EIB or have asthma, and there's just some numbers, and of course the Winter Olympics are going to have it more so. 1/3 of children and 1/2 of adults with asthma avoid physical activity due to exercise-related symptoms here. It may be because their participation is limited. Can be a component of depression. Certainly can lead to obesity if you're not exercising, and definitely a quality of life reduction. And the underdiagnosis is lack of provider awareness, prevalence and burden, absence of effective screening questionnaires. It's a difficult evaluation if you do it to the full extent. You can do it on the short side too. We'll talk about that. 39% of collegiate athletes who objectively tested positive, but only 14% were given the diagnosis. Don't quite get the whys on that, but that's some data. Overdiagnosis is, so a lot of people say, well, it's just poor conditioning or vocal cord dysfunction, habit cough. If we look at this one study, 142 children with dyspnea, which attributed to asthma symptoms produced with exercise testing, only 8% truly made the criteria. So a lot of people come in with the idea that's it, and then if you work them up hard, it's less in this case. Here's another one, 148 athletes referred for asthma, 24% previously diagnosed with EIB, but only 8% had objective testing. So most people just didn't get it. And then following objective testing, only 50% of those met the criteria. So we see mixed results in the diagnosis numbers, prevalence. The actual ultimate test is, a lot of us are doing field tests of trialbuterol before, see if it helps and all. I've been on the sidelines of many soccer games, and you see the child who's not keeping up, and they're producing stridulous noises, and so stridor, and they get pulled off, and everybody's yelling, get him the inhaler and all that. It may or may not be asthma, but the stridor is not asthma. It's the wrong symptom for that. But a lot of people get called that. You will also see a fair number of people who they were the soccer star 2 years ago, but now they're not. Well, maybe they're the ones who grew quicker, were fast when they're younger, and then gained weight and slowed down when they got older. Maybe their training partners all got extra training and became better. So you're going to get kind of a mixed history of what's going on out there, and our job's to dig into it. But ultimately, outside of just saying here's albuterol and try it and see if you get a better outcome, is to do a lab challenge here. Now, there are limitations on this. There's cost associated. The price I had for our location was about $1,000, and it's limited because you're not in the actual environment that has produced the symptoms before. You're in a normal conditioned room, so the temperature's not off. It's not necessarily cold air that you're breathing in, and you're not in the exposure of your allergens and all too. So anyway, one can do an exercise challenge. You can do a treadmill. You can do a bicycle here. Here's your specificity at 90 and sensitivity at 60. There is a standard challenge protocol for this here. Our pulmonary clinic can do a relatively stripped down challenge appropriate for most here. If you have any concerns about cardiac and need additional like cardiac monitoring, EKGs and all that, then that would be through our cardiology lab to get that done. So kind of two locations. Most of our patients, if they don't have the cardiac history, you're just going to go for the pulmonary side here. And so the intensity is ramped up over 2 to 4 minutes to get that heart rate up to about 90% of predicted max. It ends at a target ventilation or a heart rate for 4 to 6 minutes, and total challenge is about 10 minutes. It's not terribly hard. And they do have you inspire dry air on that. I've seen them do it without also, but ideally the dry air is what's reflecting kind of the cold air exposure in the wintertime. They'll do PFTs before the actual stress test, and they'll do one afterwards and up to 30 minutes after. And standard definition is a 10% drop in FEV1 is to meet the criteria, no different than asthmatic. And then reproducibility varies. If it comes out normal, do you do it again? 2 challenges, 76% had the same outcome. So got to look at the patient on that, decide if you ever need to repeat it again. And then the field challenge, the benefit of this, it's sports specific. It's in the environmental exposure, whether it be the weather, pollens, or whatever. Can be a little time consuming. It's less practical here. And then the fears, if somebody had a severe decrease in FEV1 while you're, away from where you're doing the challenge, or where you might have meds. When I was in private practice, I literally, because, being the runner guy, I take them out and run them in the parking lot at the end of the day, so I could go out there and get sweaty with them and make sure they were pushing it and all, and then we just run it and do the PFT. That's not practical for most people. Don't know if I'd recommend it for all. It does come with some risk, but it's one way to get it done. And then there is indirect challenge testing that you can do, and this is basically eucapnic voluntary hyperventilation. You exercise with an inhaled compressed dry gas. The protocol is 85% of target ventilation, 6 minutes, serial spirometry, and again 10% drop. This is another pretty easy and quick one. Unfortunately, it's not readily available. I'm not aware of anybody in Kansas City having it. And reproducibility, it varies out there. It's good to overly sensitive, if I can spell correctly. Lab availability is a difficulty, severe decrease in FEV1. So it's not recommended if your baseline FEV1 is less than 70%, and that 70% shows up in, if you're going on allergy shots or doing a challenge or something, your FEV1 is less than 70%. That's not a great time to be challenging people. So this is the method that's endorsed by the International Olympic Committee, and it is also in the military recruits. And here's just a picture I did find online of this here. I know nothing about the company. I'm not sponsoring them, or they're not sponsoring me, but just wanted to show you an example of what I could find. And then another indirect test that we used to do is called a mannitol challenge. And this was a great thing. It was basically you inhaled multiple doses of mannitol over time and did serial spiros to see. It was quick and easy in the office, safe and reproducible. Unfortunately, in 2014, it went away. So it's not currently available in routine sites anymore. It did have poor sensitivity for EIB, and so in general, not recommended. You'll find various algorithms out there on EIB. This is just one, and it's looking, when the first thing is do spirometry, look at their FEV1. If it's less than 70% versus greater than 70, you go down the different pathways, and it talks about indirect bronchial challenge all the way to the actual challenge itself has the differential and all too. I do want to point out, always get a baseline spirometry. Always look at the history for asthma, because some people have underlying just baseline intermittent to persistent asthma. If you control their baseline asthma well, get them as healthy as you can, then exercise may not affect them. So yes, they had exercise-induced symptoms, but it's because their baseline asthma was not well controlled. There are other people that either great baseline asthma control or don't have baseline asthma, but just have EIB alone. So they're kind of two different creatures there. Here's just spirometry for all those. In our group, we'll be doing our procedural competencies, and you have to go through and diagnose which defect that you may see on this. And it talks about intrathoracic and extrathoracic and all. So I just had a recent interesting case in clinic on somebody with an intrathoracic. I won't go into detail, but it was picked up on spirometry. All right, and medical management here. So warming up is key. Like I mentioned before, get that heart rate up to 70 to 80% of norm before an event. That builds in that refractory period. Having preconditioned air, in other words, wearing a mask, may be also helpful. What most people are going to want is, what medicine can I take, unfortunately, and that the hallmark has always been using a SABA, short-acting bronchodilator, and that's albuterol. It has been touted in general as the most effective therapy for prevention as well as recovery, given 5 to 20 minutes prior to, so you get a plan. The bronchoprotection is 2 to 4 hours. It can be used on an intermittent basis. If it's less than 4 times a week, that's probably reasonable, not tachyphylaxis. There may be tolerance in some people, but not all. There is a little bit more information about other long-acting beta agonists, and we'll mention the formoterol budesonide product are out there now. Initially, they don't recommend long-acting beta agonist alone, LABAs, on that, because you're not taking care of it, potential inflammatory component side of it too, and then there's some concern about tachyphylaxis alone. So intermittent basis was a thought, but again, don't use LABA alone. Mast cell stabilizers are out there, and it's the two products, Cromolyn and Nandocromol here. They do have a bronchoprotective effect, but they are not a bronchodilator, and these are given pre-exercise here. You would still probably need a SABA for rescue too. And then leukotriene receptor agonist, montelukast has the biggest name on this, and it can be either daily, just scheduled because it's easy and maybe it's an unpredicted schedule and when they're going to exercise, or you can do it intermittently, but it's got to be 2 hours prior to exercise. It again doesn't work in everybody, but it attenuates EIB in about 50% of the patients, and it's kind of incomplete protection, but there's no induced tolerance on that one. And then down here, the just ICS alone has some bronchoprotection. Again, it's not rescue or quick reliever therapy. You still need to have a SABA available here. This is certainly going to be helpful in those that have baseline asthma and inflammation. Your pheno could help with that decision making too. And then now with combination therapy with the inhaled corticosteroid and the LABA here, there is some data that it may be a little bit better outcome than the use of albuterol. So in our children that were in a peds hospital, in our children, but also in adults, you could use 1 puff of a combo therapy. Please make sure it's a quick-acting LABA if you're using combo therapy. Okay, so formoterol is the current best choice on that one in the U.S. Yeah, so some data that says that a SAVA would, a combo would be appropriate, and only 1 puff is needed. If it's not working in that given individual, then 2 puffs prior to exercise would be a reasonable thing too. And then if they already have baseline asthma, taking it, on a regular basis may provide, because it's a 12-hour bronchodilation, they may get away with not needing it as long as they remain on combo therapy daily. Ipratropium is the one anticholinergic that's mentioned as inconsistent results. It would not be the mainstay or the starting point for EIB here. It can be an add-on therapy, but it's pretty inconsistent and inconclusive use on that. Do remember to maximize the upper airway, because you got to breathe through your mouth and your nose. If you don't believe that, try to go around with your nose clamped by your hand and see how that works for you. So there's some information about using an intercorticosteroid nasal spray. It has a mild reduction in EIB and more so in atopic patients. The methylxanthine is almost out of the market these days. Theophylline, no benefit with that. You'll find some articles on caffeine. If you love to drink a lot, it can help, but it's probably not well tolerated in most to do that many. And then antihistamines had inconsistent protection across the patients. I bring up the International Olympic Committee because they have pretty strict guidelines. You would hate to ruin somebody's career or competition because they got tested or want to report a med that is against the what's called WADA regulations, World Anti-Doping Agency. I don't pretend to have any expertise in the IOC and WADA. I refer you to the website to see what the current list is. I wouldn't want to steer anybody wrong, but it does have a list of what's allowed and what's not allowed. We mentioned before about the pre-exercise warm-ups here, strong recommendation, and there's good evidence here. We mentioned the heart rate, refractory period that's induced, and exactly why we're not sure, but PGE2 may be involved. And this is just showing the refractory period coming back up after exercise. And we talked about preheating here. You'll also, I put vitamin X because the name of the vitamin changes year to year on what super vitamin is going to solve your problems here. But currently there's no strong recommendation for any supplementation with vitamin X omega-3 or even a low sodium diet. Back to our case study, his pulse ox on room air was 100%. He had normal vital signs, blood pressure, etc. He had a pretty normal physical exam. The chest x-ray was normal. His exhaled nitric oxide was 10 parts per billion, so that's in the normal range. His baseline spirometry had an FEV1 of 95%, and it was non-obstructive here. So he doesn't appear to have baseline uncontrolled asthma, and he had no history to suggest that. An exercise challenge was done with a post-FEV1 with a 15% decline. As you remember, we use 10% as the cutoff now, so he makes the definition. He was prescribed albuterol to be used 15 minutes prior to the practice or game. And because it was not always predictable that he was going to be able to get it before that, here put him on Montelukast to be taken daily, scheduled here. Talked about the importance of warming up the face mask, the avoidance of cold air, and then certainly recommended a follow-up to assess response and then repeat spirometry. So in summary, it's a common problem, more so in asthmatics and endurance athletes in the cold air. Standardized testing is recommended in the diagnosis, but you got to pick and choose appropriately due to cost and all. It's fairly easy just to say, yeah, maybe, and try this and see if you get a different outcome. I didn't mention peak flows here because we don't use a lot of them anymore, and at least in my practice, but peak flow meters can be done pre and post exercise with and without albuterol, and potentially you can get data that might support some drop in lung function. My problem with that is people following through, getting consistent testing. It's very effort dependent, and I probably only get about 20% of the people respond when I give them this little chart how to fill out and do the peak flows. So that's kind of fallen out of favor. And then certainly consider the patient outcome. If they're a high-level athlete, they're going collegiate, Olympic, or if they're in the military, then having a more formal diagnosis through standardized testing would be recommended. And currently, I think it's fair to say pre-exercise albuterol is the standard, but the combo therapy certainly can be entertained too. This is the allergy practice parameter on exercise bronchoconstriction, last updated in 2016. And these are the remainder of my references throughout the talk. And since we had to start, we must have a finish. We do have Dr. Chris Randolph used to do a lot of our talks on EIB, so you'll find some of those on our conferences online in allergy. They're a little bit dated just because it hasn't been invited back for a while. And then Middleton's has a chapter on this too. So.